I wrote the test this weekend. It's being previewed. Make sure you know what permethrin type strength you're supposed to use. All right. Today we're going to start with HIV. Who knows that we have people with HIV in the military? We actually have people with HIV in the military. I, as the PA, was not aware of that until I found someone with HIV. Was I not aware of that? I did not know. And I was a medical provider already at that time. So understand, we have people with HIV in the military. Okay? If they're doing medical jobs, they get pulled from that medical job, and they get put in some administrative job where they do not deploy, and they don't do patient care. But we keep them. Each service has its own little reg as to how they treat them and take care of them. Okay? For the Army, we keep them, put them in an administrative job. If we cannot control that CD4 count, generally we look at CD4 count of less than 300. What's the magic number? 200. 200, right? So the magic number is 200 people when they go from HIV to AIDS. Okay? But for us, within our reg, generally the number is 300 when we put them to get medically retired. All right, so they all end up going through the IVS process. All right, so that's just an FYI, because as a PA, when I first started, I was not aware. I have found multiple people with HIV in the military. You know what I did? I just went ahead and gave it to my doctor and let him take care of it. Okay? And then I went and asked, hey, what are you supposed to do with these things? And then he explained to me, and then, okay, I got it. Right? But first time I found one, I didn't know what to do. Look at your SOPs wherever you go. It tells you what you're supposed to do when you get an HIV patient. All right? There's a lot of counseling, and then they end up going to ID. Now, the reason why I tell you that is because initially they're going to go to ID for control. Do they need to be on antivirals or not? Depends on what they're looking like. Depends on what their CD4 count is. Depends on what their viral load is. Depends on a lot of things. Right? Depends on their CD4 lymphocytic count. Right? A lot of depends. But what there is no depends about is that once they're controlled, once they get to whatever job they're going to go do, you may be their PCN. So you may be seeing someone with AIDS, or HIV, probably not AIDS, but if you're a National Guard person or a reserve person who's going to start working on the outside, you can go work in an HIV clinic. And you start seeing these folks right away. Right? But within the military, these people still have their jobs, not deployable, but they may be assigned to your panel, so you may be seeing an HIV person. I've had a couple, in different positions I've had a couple that have come, and as they have become part of my panel, patients that I'm supposed to take care of, the saving grace for a lot of these people are like, hey sir, I just want to tell you I am HIV positive. So that tells me that number one, they're HIV positive. Number two, the next question is, hey, are you being followed by ID? Generally the answer is yes, because they already know. And then depending on what they have when you're taking care of them is whether or not you need to talk to ID about the medications you're going to give them or not. All right? So some of this stuff isn't necessarily black and white. Some of it is a little bit gray, especially when we talk about opportunistic diseases, which generally do not occur unless they drop below 200, but the possibility is always there. There's two specific definitions for AIDS. One is CD4 count less than 200. The other one is being HIV positive, but having an opportunistic infection. Okay? That'll be covered in the slides here in a bit, but I need you to understand that just because they don't have AIDS doesn't mean that they can't get put into that AIDS category, all right, based on the definition that we have. Good? Everybody understand that part so far? Questions? No? Okay. So we're going to talk about HIV today. Look at it, it's all over the world, except for Greenland, right? Wow. Okay. So this is not necessarily exact, but the thought process is that in the first half of the 20th century, there was a chimpanzee-related disease in Western Africa that crossed over and infected humans. The main way they thought that this occurred was that someone in that region ate some infected chimpanzee meat, which got us infected, and it started going pandemic from there. Right? Those are the origins of HIV, is what they think. Right? Around the late 70s, it made it to the US. It wasn't until 1981 till they actually defined AIDS. So now we're talking, hey, it arrived in 1970. 11 years later, we finally decided to define something. So if you haven't noticed these little patterns of, hey, we got something, decade later we're like, oh yeah, this is what it is. Right? There's sometimes decades that go between us figuring out that something's there, but it takes a little while to figure out that we got it. Okay? In that interim, there's a lot of people that are suffering. Okay? And sometimes for us as medical providers, we're kind of left out there. We're kind of left hanging because we're not necessarily sure what to do. Right? And in this case, as they continue to progress through medications, mostly after 1981, right? Because it wasn't until the mid-90s that we came up with HART. I don't know if you guys remember that from your pharmacy classes. You have HART. HART is the older term for the medications that they used to use. Now we just use HART. HART is combination therapy. That is the default that we use nowadays. But HART didn't start till like the beginning of the 2000s. We're talking 30 years before we actually got something. Or we go to the mid-1990s, 20 some odd years before we get something that's actually going to help us help our patients. So just keep that in mind when we're dealing with something brand new and when we're dealing with patients that are in that same transitional state, trying to figure out what that disease process may be. Okay. There's two types of HIV. Most people don't even realize that. Most people don't even worry about HIV 2. HIV-1 is a standard one that we think about all over the world, particularly in the US. Okay. That's where it destroys your CD4 count, your lymphocyte count. Really targets CD4 T killer cells is really what it targets. And then if you look at the other one is pretty isolated to West Africa. It's got a much lower transmissible, much lower viral rate, and slower rate of progression. Now, there are a couple of pockets outside of West Africa there, but you really don't hear much about HIV-2, not to mention the medications that you use for HIV and HIV-1 also take care of HIV-2. Right? There are very rare instances where HIV-1 is also co-infected with HIV-2. They have a slightly different makeup, but they still do basically the same thing about attacking your CD4 cells. Right? Now, how do these things generally present? And this is the part that really gets a lot of folks. These folks usually present with flu-like symptoms or mononucleosis-like symptoms. Okay? So what does that mean to me and you as providers? That means when they show up in your office feeling a little sick, barring you don't understand their lifestyle or you don't ask about a good HPI about their lifestyle, you may just completely miss it, right? It's like, oh yeah, flu symptoms, you look like a pretty healthy person. All right, you should get better. Hey, guess what? They get better. Oh, great. And then as time goes on, that CD4 count starts dropping and that viral load starts going up, but we still don't know that that individual actually has HIV. All right? That's the confounder with the presentation of HIV initially. Okay, this slide is important. I suggest you remember this slide. Big ones that you need to remember: receptive intercourse between 1 to 100 and 1 to 30 people. Okay? Who does receptive intercourse? I'm not asking for you guys personally to do it. Okay? I'm asking for the people that individually do it as a lifestyle, right? Men who have sex with men generally do this. That means that they have a higher propensity of getting HIV. Right? That is why we look at some of these numbers. Right? And the other one that I kind of want you to remember is sharing needles, IV drug use is 1 to 150. So every one person, per 150 people end up getting it. Those numbers are pretty small, right? That ratio. So as you're doing your HPI, these are some of the questions that you may ask if that is what you're thinking, right? So some of these numbers will put it in perspective based on the individual person or patient that you're talking to. Right? Now, the World Health Organization, WHO, in 2021, said about approximately 38 million people in the world have HIV. 1.7 million of them are less than 15 years old. That's a pretty big number, right? Most of it is in Western and Sub-Saharan Africa. Okay? Not in the U.S. We have our own number in the U.S. It's in the hundreds of thousands, not in the millions. All right? But HPI stuff, pretty important for these numbers. Okay? 1.1 million people living with HIV. Talking U.S. now. 1 in 5 are unaware of their infection. Right? As we said, the presentation of this is very insidious. Just seems like HIV, seems like flu or mononucleosis. But if you look at gay and bisexual men, represent 2% of the U.S. population, but account for 67% of people diagnosed with HIV. That is not to point out the obvious, but it is to bring out the number for you when you do your HPIs to understand asking lifestyle, depending upon what you're thinking, is extremely important because it can lead you down a different road. Right? Approximately 10,000 people became HIV positive in 1979 to 1983 from contaminated blood products, including factor VIII given to hemophiliacs. Right? We did not start testing for blood for HIV until 1985. What do we say, 1980 for HIV, and then 1985 for checking blood. That's 5 years later. But we already knew we had this problem since 1970, right? Why did it take 15 years to figure out, hey, let's check our blood as we give it to other people so we don't transmit HIV to other folks, right? So there's a time frame there as you talk to your patients and they're like, yeah, I had a blood transfusion from a car accident in 1980. Might be somebody you may want to check if they start showing up with some symptoms. Okay? Florida, California, New York, highest number of new AIDS cases. So this goes back to our prior statement. Depending upon where you work is what's going to be prominent. In this case, Florida, California, and New York have the highest numbers of AIDS cases. Right? So if you're in any of those states, particularly the big cities, Okay? This may be one of those things that you may want to check on your patients. Okay? You know, work here in San Antonio, there's about 6,000 people here. All right. So real quick before we start on the slide, you guys see my pointer, right? Okay, this right here should not be what are CD4 cells. It's not these. Okay? These are other cells that can be infected by HIV. Okay? These are other cells that can be infected by HIV. CD4 cells are the specific type of cells that are targeted by HIV. There are probably about 6 specific types of CD4 cells within the body that go in and help your immune system. Now, what do I like about this slide? You should have probably seen the slide in pharmacology, yes? Don't remember? Okay, that's fine. All right, but what I do want to point out is that there's 1, 2, 3, 4, 5, 6, 7 different areas that we have medications that attack this problem now. We didn't before, we do now. Okay. So here it comes in, it attaches to your protein. Okay, your protein is either GP41 or GP120. Once it attaches here, there's another one that you need fusion, where it deposits its RNA, right? HIV is an RNA retrovirus. It deposits its RNA and it goes inside your system. Okay? Once it goes inside your system, okay, it does reverse transcriptase. Okay? That RNA gets converted to viral RNA, gets converted to proviral DNA. Okay? Why is that? Okay? Because our cells are DNA, right? Our cells are DNA. This is an RNA virus. It does reverse transcriptase and it becomes proviral DNA. Okay, that's what this little area here does. Okay, then it integrates into the nucleus, where it meets our RNA strand, and because it's proviral RNA, when it penetrates, it's able to mix in with our specific DNA inside the nucleus. And as it does that, it hijacks the machinery. It hijacks the machinery, it takes over the cell. So our body is no longer in charge of that cell, that virus is in charge of that cell. Now that that virus is in charge of the cell, it has 2 possible things that it can do. It can either go latent or dormant, it's just going to hang out. It's my vacation time, I'm not doing anything, I'm just hanging out. Or it can start replicating. If it chooses to start replicating, it's going to form mRNA. Okay? It's going to form 2 things. It'll form mRNA, okay, you can see that right here, and it will also form a protein that's going to allow it to break out of the cell wall. All right? So once that occurs, it gets pushed out here to the translation area. It combines with that other protein in the assembly area, which is really right against the wall of the cell. The extra protein is going to allow it to be released, and it's going to bud back out, and it's going to go find another CD4 cell and infect it, and it's going to continue on and on and on and on. A lot of times, it takes a long period of time before a person actually becomes an AIDS patient, because this is very slow, very subclinical. So that's generally the pathophys of how this stuff really works inside the body, particularly inside your cells. All right. Okay, so symptoms occur 2 to 4 weeks post-exposure. Can be asymptomatic. Remember, these symptoms that we're talking 2 to 4 weeks after exposure is your initial presentation. Looks like the flu. Looks like mononucleosis. That's what we're talking about here, 2 to 4 weeks later. All right? Now, this is the important piece right here. Okay. Antibodies in blood, close to 100% detectable in 3 months post exposure with an average of 63 days. What does that mean to us as providers? Okay, what that means for us as providers, even if this guy shows up in your office with influenza type symptoms, and you know that their lifestyle is risky, right? And you know they're gay or bisexual, whatever it may be, and you test them, your test will be negative. There is an initial window, okay, and there it's telling you that it takes 3 months before it becomes 100%, or anywhere between 3 to 6 months, or 3 to 6 weeks before you start getting some stuff in your system to have this person be positive when you look at lab results. Which is why you have to be careful when you do lab results. It's like, hey, you don't have it because you're negative. Okay, well, there's a slight window there that this person will be negative. So you have to retest later. Okay? So knowing some of these time frames, you're going to kind of figure out when you should test appropriately. Okay? So here's a quick snapshot there, right? So the red line is your CD4 count, your blue line is your viral load, right? So you don't have any of it, you get it, pops up, your CD4 count's already waiting, CD4 cells are already waiting, they peak, and as they're fighting, they start coming down. Okay, so this window right here, if you were to test it, this person's gonna be negative. So you have to be careful the window, time period that you actually test for HIV. All right. The next part, which is kind of nice with this graph, is here's your viral load, right? Your CD4 count is beating it up and it's winning, right? Here's your CD4 count. Well, check it out. It's not going back up to the exact level that it should be. The viral load is still there. It's going down because your CD4 count's winning. But guess what? Subclinical over time, that viral load is going to continue to affect your CD4 count. And as it does, there's going to be a point here, this is your less than 200, where you actually cross over to AIDS. Right? What that time period is, you don't know. It could be anywhere from 2 to 10 years or so. Right? It really depends on a lot of things. It depends on your host's immune system, depends on viral load, depends if they're taking any meds, depends on their diet, depends on their health. Right? There's a lot of things that go into the amount of time that'll take this person to reach it. Some folks don't. The nice thing about nowadays is that we really don't reach it because of the types of medications that we have. So it's a great time to start treating some of these things because now we have the medications that are required for it versus before, at least when I started, we had one medication, AZT. It was extremely expensive, it had a lot of side effects, and they realized over time that this stuff started becoming resistant to the one medication that we had. So nowadays, where we have tons of antivirals that have shown great efficacy in treating this. All right. This one, you need a confirmatory lab. All right. You're either going to do an HIV ELISA screen or you're going to do a rapid antibody test. If it does come back positive, you need to do a Western blot. A Western blot is your confirmatory test. Now, the only exception to that is if you do the rapid antibody test, your confirmation test can also be the ELISA as well. Okay? That is the only exception that we have here for those 3 tests. All right. So what else are you going to draw when you're looking at these guys? You can do a CBC. Some of these medication side effects affect your bone marrow. What does that mean? That means that it could possibly cause you some anemia. Okay? So you have to be careful and you have to know some of the meds and some of the side effects that they cause, which is one of the reasons why we should do a CBC. If they do have that, that's going to lead us to using a different type of medication later on down the road, which would be hematopoietic type stuff. But we'll talk about that when we get there. You have an absolute CD4 lymphocyte count. Okay, that's your predictor of progression. That's, hey, is it less than 200 or not less than 200? Right? If it's higher than 200, the likelihood of it not necessarily progressing on is great versus it going to less than 200 then obviously it's progressing on and we need to do something to change it. The CD4 lymphocyte percentage says less than 14% susceptible to opportunistic infections. That is a proportion of all the lymphocytes you have. Most of the folks say that that is the most stable number to look at. All right? That is the most stable number to look at overall because they're looking at all your lymphocytes, not just your CD4 count. But for the most part, for us laymen, we usually look at CD4 count and we look at viral load. That's the next one. Viral load is what you will look at in order to determine whether your medications, right, your treatment plan is working or not working. Okay? So keep that in mind, highlight that viral load is what you use to monitor progress of medications. There's newer tests available. They're still doing studies on them. Your labs have protocols for doing HIV stuff, so whenever you go someplace, if you do know that someone is probably positive, then make sure you write that when you're requesting specific labs. Okay, so here when we talk about CD4 count, here's your lymphocytic count, predictor of progression. That's your CD4 count, 200 or so, less than 200, greater than 200. When we do these, we don't do specific time hacks like snapshot pictures. Okay, we need to look at the trends. Are they going up or going down? That's really what's going to determine what we do. All right. And then there's your CD4 lymphocyte percentage, which is also a predictor of progression. Remains the most stable out of all the CD4 counts that we do. And then you can use it, the CD4 count for monitoring as well. But if you look at the bottom, that viral load where it says monitoring, that's the much better way to track any of this stuff. We generally have 3 stages for monitoring this stuff. Right? We have stage 1, which is greater than 500. That's great. Most people, the standard range for CD4 counts anywhere between 500 and 1500. That's your standard range. So stage 1, greater than 500, wonderful. No issues, no problems. That's where everyone should be. Then you have stage 2. That one goes anywhere between 200 and 499. Those are the ones that you have to really keep an eye on. And as you start giving them medications, you have to see whether that's going back up or it's going back down. And then stage 3, that's less than 200. That'll be going into the age category where you have to be more aggressive. This staging only works for ages greater than 6. So ages greater than 6 is what this staging works for that we look at. All right. Here's a whole bunch of signs and symptoms. Anything specifically pop out at you? There's nothing in there that really pops out at you, right? Who knows what B symptoms are? You guys remember what B symptoms are? Anybody talked to you about cancer yet? No? Alright. B symptoms are the big ones that you really look for, right? So you look for fevers, night sweats, loss of weight more than 10 pounds. Okay? Over a 6-month time period. Right? And nighttime bone pain. Those are 4 big ones that we really look at when we talk about cancer type stuff. Right? And if you look at this, you already have 3 of the 4. You have fever, you have weight loss. You consider myalgia as bone pain, but that's more muscle pain. And then you've got night sweats. Okay? So you've got 3 of the 4 right off the bat. Some of that stuff should kind of lead you to some sort of workup. Right? Especially if they have those symptoms. Because those are kind of concerning. Okay? So therapy and treatment, antiviral treatment is recommended for all patients. All patients. Okay? You minimize your stress, your immune system tends to stay higher. Okay? Avoid exposure to infections. Right? Because now we're talking, if their immune system is dropping, and the likelihood of getting some sort of infection, any kind of infection, is greater than it would be for you or I, right? Adequate exercise, because that's going to keep them healthy. Okay, maintain a nutritious diet, because that's going to keep them healthy. Avoid situations that could lead to depression. Depression will decrease your immune system according to a bunch of standards, a bunch of studies. So we can let them know that a lot of the medications that we have really have great efficacy. And then practice safer sex. Right? Because we know men who have sex with men are the highest probability of patients. So here's a little transition, HIV to AIDS. Okay. So HIV infection, CD4 healthy T cells. The T cells, CD4 T cells are what usually gets attacked, and then cells gradually deplete over approximately 10 years. That's give or take years. Okay. It's really dependent on the patient. It's not like, oh, it's got to be 10 years. It's not. Okay. Ultimately, people don't die of HIV, they die of AIDS. And within AIDS, whatever opportunistic infection they get is what kills them. And there it tells you susceptibility to the opportunistic pathogens or opportunistic cancers. Okay, two things, cancers or infections. Right? When your CD4 count was less than 200. All right, this is my favorite picture. This one and the lime's picture. But this green thing is a CD4 cell under electron microscope. Right? Those little red dots you see there is all the HIV virus. It's attaching to that CD4. And it's trying to penetrate to get in there and take over. I think that's a great picture. Okay? Remember, this stuff can affect any part of your body. Right, once it becomes AIDS and it drops less than 200, right? The treatment is concentrated on whatever the disease process is. If it's affecting your lungs, it's a system involved, you target the disease process that's affecting your lungs. Okay? It'll be a combination deal. You're still going to treat for antiviral stuff because you want to make their virus load go down because it's up. And then you want to also treat whatever that infection is that's getting you, right? Because as you mentioned earlier, what's going to kill you is infection, not the HIV, all right? And then infections often occur at certain CD4 counts. And we're going to look at a couple of charts, and these charts you need to remember, okay? So here's your definition for AIDS, either CD4 count less than 200 or having HIV with an AIDS-defining illness. Now, the CDC has already put out what those disease processes are. Right? And these are those disease processes. Okay? So even if you have HIV, if you have any of these, they will technically consider you having AIDS because you're having an opportunistic infection. Okay? Candidiasis, cryptococcus, Cryptosporidiasis, cytomegalovirus, HSV, right? So candidiasis, cryptococcus, and pneumocystitis is fungal, right? Cryptosporidiasis and toxoplasmosis are parasitic. Cytomegalovirus is a herpes type virus. HSV is a virus. Kaposi sarcoma and lymphoma are cancers. Right? So we're not only talking viruses, right? We're also talking cancers. Mycobacterium is a bacterium. Right? So it's a whole bunch of different things that can actually get you. And here you can tell, it tells you, right, the different places where it can affect you. Kaposi is less than 6 years of age. Okay. More common. All right, you need to know the last slide. You need to know this slide specifically, okay? Because these findings on history is what your symptoms are probably going to be on your scenarios. All right. recent onset of retrosternal pain on swallowing, history of oral candidiasis, tells you that it's probably candidiasis. And your scenario probably won't tell you that you have a history of candidiasis. It'll just tell you recent onset of retrosternal pain or retinal changes, kind of low spots or exudates, that tells you that it's cytomegalovirus retinitis. Right? So you need to know the findings. These will be on the test. Oops. All right. Violaceous plaque-like lesions. Those are bluish, purplish, sometimes brownish lesions that pop up all over your body. It is considered a cancer. It is called Kaposi sarcoma. Usually happens in people less than 60 years of age. Pops up on your torso, it can pop up on your legs, back, neck, arms. It can pop up anywhere on your body. It is more of an external thing than it is an internal thing. Even though it does attack your internal areas, visually you'll be able to see that they have Kaposi sarcoma. Right? So 4, 5, 6, and 7 are all together. Right? That does the Girovecchi and Mycobacterium avium. So dyspnea, exertion, non-productive cough, chest x-ray, diffuse bilateral interstitial infiltrate. Okay. I would say remember that, but diffuse bilateral infiltrate, interstitial infiltrate, very common for a lot of pneumonias. Okay. So that needs to get put into context per the HPI, right? Are we talking to a person that has HIV or not? Toxoplasmosis, it's a neurologic deal. So 8 and 9 go with toxoplasmosis, and 10 and 11 go with pulmonary tuberculosis. So you need to know this slide, and you need to know this slide as well. Okay. What I like about this slide is this right here tells you the CD4 count that you have to concern yourself about for the particular opportunistic infection to occur. All right. So if I'm talking MAC, usually it occurs at less than 50. MAC usually runs together with Girovecchi because they're both in your lungs. But Girovecchi will probably pop in first at a lower than 200 CD4 count. Okay? So if I give you a CD4 count less than 199, okay, with those pulmonary type symptoms, is it going to be MAC or is it going to be Girovecchi?
Girovecchi.
Probably Girovecchi, right? Because it's 199, not less than 50. Okay? This means that your body can still handle MAC above CD4 count 50. That's really what this chart is telling us. Not to mention, Girovecchi is the most common opportunistic infection associated with it. Toxo is the most common space occupying lesion in AIDS-infected patients. So as you go through, not just this class, as you go through all the classes that you'll be doing, okay, try to pick up all your most commons. All right, on your paints, generally they target a lot of most commons because they want you to know the most common stuff when you're out there practicing to be able to catch, so you can treat. This is what Kaposi sarcoma looks like. As you can see, it's all over his body, over his back, arms. Okay, he probably has them on his legs as well, but these are your violaceous plaque lesions. All right. This is visceral Kaposi sarcoma. Usually affects more the hard palate. Okay, so here's a couple-ish bluish type lesions. See them all right here. Okay. This is what oral candidiasis looks like. You can scrape this off. Excuse me. But what you'll find is going to be red, inflamed tissue, and as you're scraping it off, it may start bleeding. Okay? So you got to be careful. You don't want to necessarily start scraping stuff off, but you don't necessarily need to scrape it off. This is esophageal candidiasis. All right, as you saw in the mouth, same deal. You've got all these white lines right here. Okay. This is all candidiasis going down the throat, right, going down the esophagus. You guys already had HET last semester, right? Yes. Okay. So you guys know that this is what a vessel is supposed to look like. right? Nice, clean, no silvering, everything looks like it's staying within the vessel like it's supposed to. But then you take a look at this vessel, and you got all this stuff over here leaking out. This is what we call exudates, right? It's coming out of the vessels. And then you've got all this white stuff, which is what we call cotton wool spots. Okay, all those areas on the macula are losing vascularity. All right, so things that you're going to find on here, they're on that other sheet as well, the cotton wool spots and exudates on the macula for CMV retinitis. Okay, this is toxoplasmosis. This is your mess. Right? So toxoplasmosis causes what we consider mass effect. That could be some sort of lesion, that could be some sort of tumor. The deal is that it's exerting pressure on the intracranial portion of your head. Bone does not expand, right? So all the soft tissue in there, when you've got a mass that's growing out, is causing intracranial pressure. Key point to understand that is, as intracranial pressure is building, your neurologic system is going to take a hit, so you're going to have neurologic effects. The other huge thing to remember about that is you do not do a lumbar puncture when you have a mass effect. Everybody understand why we don't do lumbar punctures? Yes, no, maybe, no, okay. With mass effect, remember, you're creating intracranial pressure. That's going to run down your spine, right? So if I put a needle into your spine, draw some CSF, so I can send it off to the lab and figure out what you got, do you think that intracranial pressure is going to allow that needle puncture site to stop oozing out CSF? The answer is no. I'll tell you right now. The answer is no. That intracranial pressure is going to keep pushing down, and it's going to try to find a way out. And the only way out is that hole. So that hole will not close up. If you leak out all your CSF fluid, you're going to have a brain herniation. Which is worse. That's a neurological emergency. Don't want to do that. Don't want to do the lumbar puncture when you have a mass effect type issue going on in your cerebral area, or any kind of intracranial pressure. You don't want to do that. Now, if you are going to, you may want to talk to a neurologist before you start doing some stuff like that. So if they're going to do it, hey, great, let them do it. Let them figure out, hey, what kind of pressure are we going to put on this thing to stop it from oozing out, considering there's intracranial pressure going on. Okay? This is probably not the best picture for Girovecchi, but remember we talked about the diffuse bilateral interstitial infiltrates. I don't know how much stuff you remember from radiology last semester, but these are the bilateral infiltrates. They should be a little bit more jagged, a little bit more diffuse, but your positive arrows point at your little diffuse, hazy areas of bilateral interstitial infiltrate. And you can also get herpes zoster. The thing about herpes zoster, it follows a very specific neurologic dermatome. In this case, it's following cranial nerve 5, right? The cranial nerve 5 comes out here, it goes to V1, V2, and V3. Okay, so this girl looks like she's hitting V1 and V2. How do you differentiate some of this herpes zoster? Look at the middle of the line. It's only on one side of her face, so it only follows one side of the dermatome. Same thing with the tongue here, same thing with the side of this guy's chest. Okay, it follows a very specific dermatomal route. Same thing with this guy's back and buttocks area. It follows one specific dermatomal route. That's how you denote herpes zoster. So here's an initial workup. Right, you're going to do CD4 count, you're going to do a viral load. Here it's giving you specific time periods every 3 months. Okay, unless the patient's stable. Okay, you'll do CMV, toxos, toxoplasmosis, IgG, serology to figure out whether they have CMV or toxo. You'll do a PPD, right, because that's going to tell you whether or not this person has tuberculosis, right, because that's another one that can get you. A lot of times you want to do an STD panel, depending on why they have it. That high risky lifestyle may still show that they may have something. Right? Baseline ophthalmologic exam, because CMV retinitis will change structure of the macular portion of the eye, in which case if you do a baseline and see what it looks like initially, you can compare for progression, right? You can do a hepatitis panel for liver check, right? Females, you can do routine gyne exams. Follow the ACOG guidelines. They will tell you what you're supposed to do with those GYN exams for HIV/AIDS patients. And there's a whole bunch of vaccines there, Hep B, HPV, influenza, meningococcal. If they can get a vaccine, you probably need to give it to them, especially if they are above CD4 count 200. If they drop below 200, do not give them live vaccines. Questions why? Question is why. Okay. So understand, if your CD4 count is less than 200, do you think your immune system is going to be able to fight or compile antibodies against whatever that vaccine is for? Probably not, right? So we don't want to give these folks live vaccines at that point. So if you want to give some vaccines early so that they can be 100% vaccinated against everything that you can possibly vaccinate them against, that could eventually kill them, that's preferable. But again, anything less than 200 is really not going to be helpful because your immune system may not be able to develop these antibodies. Therapy for opportunistic infection and malignancies is really what you should target a lot of your therapy for, right? So you're targeting two things. You're trying to make sure that that viral load goes down with the antivirals, because you're doing it in combination with now whatever the treatment is for the opportunistic infection, right? We know if it's HSV, we're going to give them a cyclovir or vanciclovir, right? But we're still going to give them those antivirals, okay? So it'll be a combination treatment. Prophylaxis for opportunistic infections and malignancy, that is your vaccines, or if we're talking a lot of respiratory chest problems, now we'll probably say, hey, let's go ahead and prophylax them with, daily doses of azithromycin. All right. Then we have HAART, and then we have HAART. So, big difference. HAART is the original term. It started around the 1990s when we first started coming out with antivirals. And that technically was a regimen of 3 different medications from 2 different classes. You guys remember HIV or AIDS treatment from pharmacology? Have you guys had that yet? Okay. We've gone from HAART to ART. ART is a new term. ART is an understanding of default of combo medication use. Okay. That's really what that becomes. So HAART's the old term. HAART's a new term, and it implies combination therapy by default of antivirals. All right. Now, for those of you who are going to work outside in the civilian sector, socioeconomic insurance is going to be a huge aspect to this. Right? So, I don't remember exactly the time frame. I want to say 2021 is when Cabenuva came out. Cabenuva is an injection medication that they use to treat HIV. Okay? It's 2 medications. 2. 1 injection once a month. How much do you think that medication costs? Okay, there's 2 dosing types, 400, 600, and there's 600, 900. Let's go for the lower. Let's go for the 600, 900. How much do you think that 1 injection costs? Say again? Okay, we got $5,000 here. Anybody else? All right, higher or lower? Higher or lower?
Higher.
Higher? Okay. It's not higher. It's not higher. Okay. So it's not $5,000. So it's a little bit less. You're pretty close. Right? It's $4,400 for 1 injection once a month. You guys make that much money in a month? Some of you guys do, some of you guys don't. Okay. Now let's remember, we're talking civilians. We're talking whether they have insurance or not. Do you think they can afford this? Okay. Well, this is where that socioeconomic aspect, right, comes into play when you're working in a civilian sector. When you're here in the military, it's not an issue. I can get different types of HIV medications to give folks. Okay. Now, there are generic types of medications that we give them that also work as effectively. It's just the dosing is not going to be as simple. Right? But I just want you to understand that there's a cost associated with this that some people can't meet. All right? And then if we're going to the higher dose, the 600 to 900 dose, that's $6,600 bucks. Right? That's $2,000 more if we're talking we need the higher dose of medication. So things to keep in mind. And then ultimately there you've got chemopoietic stimulating factor. Right? We try to stay away from that. That has a lot of bad side effects. Nausea, vomiting, injection site irritation, fever, chills, edema. So if we don't have to, we don't use it, but understand the side effects of some of the antiretrovirals that you use. So pharmacology comes really into play here, right? Because some of these antivirals, although the newer ones have way less side effects than the older ones, right? The newer ones still may cause some decrease in bone marrow production of red blood cells, right? And if you do a CBC, you may see that some of these guys may have anemia. So how do we spur that? We give them hematopoietic stimulating factors to kind of get them to make some more red blood cells. Okay. But again, got to be careful using that. AZT, which was one of the very first antivirals that we were using for HIV and AIDS. One of the biggest side effects is anemia. Okay. And just keep in mind some of the pharmacological aspects of some of this stuff. All right. We'll do this one real quick. So the basis for this slide deck is here's your disease process, here's your treatment. It'll be a cyclovir or vanciclovir. Toxoplasmosis, it'll be promethazine in combination with trimethoprim sulfamethasone. Okay. What this is telling you right here is that whatever the opportunistic infection is what you treat with. Okay. So don't forget that it is a combination treatment of trying to take care of the opportunistic infection and still trying to keep their viral load low. Okay. So that is how you were supposed to treat these patients. That's really what this is telling you. And it's telling you the specific medications that you should be using for each of those opportunistic infections. Anybody have any questions on this slide? No? Yes, maybe? All right, let's go ahead and take a break. All right, a couple of things I want to point out. Your slide 10 is a little different than what I put up here. The slide that you have is the correct slide. Okay, so the slide deck you have is the correct slide deck. And mine is a little bit older. Don't know why, but I'll adjust that for the next one. The other thing I want to mention for the biowarfare slide, I think there was another one slide that was a little bit different. If you go into Canvas, the updated slide deck is in there. So if you'd like, you can go back down there, you download the slide deck and compare. It's only one slide that's a little bit different. I believe it's I just separated out the bubonic plague, so that would be Doxin, Cipro, and then the septicemia and pneumonic plague, that's gentamicin. I just separated those just to make it a little bit easier for you to understand. Otherwise, the information is still the same. Okay. You guys have any issues or questions on any of that, please let me know after we're done, okay? All right, so continuing on, when we look at this regimen, okay, without exception, benefits of treatment outweigh any concerns about the drugs and the side effects that you may use. All right? So let's make sure that we treat everyone Now, what do we look at for treatment? We look at virology efficacy. Okay? There have been some resistance noted with some of these HIV strains. Okay? So you need to make sure that what you're giving them is actually going to work for them. Okay? You need to look at toxicity of some of these antivirals in combination with some of these other medications that you would give in reference to opportunistic infections. Antivirals are processed through the kidney, so make sure you do creatine clearance to ensure that your kidney's okay to handle all this stuff. Okay? Pill burden, things nowadays, which is kind of nice, that they have 2-3 medications in just one pill, or they have 2 or 3 medications in just one shot. So that's kind of a nice thing, but understand, with some of these, when we talk about socioeconomic issues, sometimes we can't afford the generic. So we have to do each individual pill generic. So instead of me giving you one pill with 3 medications in it, I give you 3 generic pills. Okay. So that pill burden starts building up if you can't afford the brand name stuff. Okay. The dosing frequency, some of them are daily, some of them are monthly, like the shots. Most of the oral medications are usually daily. So remember, if you give them 3 pills, and now they have an opportunistic infection, you give them 2 more pills, that's 5 pills right off the bat, right? If those 3 pills aren't enough for the antiviral issue, now you're going to add 2 more pills on top of that as part of their regimen. Right? So now that puts you up at 7 pills. Right? So sometimes you have to be careful with the dosing. You have to be careful with that pill burden. Okay, drug-drug interactions, of course, with some of the medications that you may use for the opportunistic infections, they may interact with some of the antivirals, so make sure that you check. I use Hippocrates. You can download that, I think it's free. And you can put drug interactions in there, and it'll tell you what that drug interaction will be to make your life a little bit easier, or pharmacology type stuff. Another thing that I use is the Sanford's Guide. Have you guys heard of that? Yes, no, maybe? Okay. You can download that to your iPhone or iPad, and you can use that once you start practicing. You can put in whatever disease process you're thinking about, and it'll tell you what the dosing is. It'll tell you resistance. It'll tell you when and where you should give it. It'll tell you what type of medication you give in certain parts of the world or country. So that's a pretty good book, especially for infectious disease. And it's a little handbook that you can or put on your iPhone. You have drug resistant testing. As we mentioned earlier, there are some drug resistant HIV strains. So you have to use specific antivirals for that. And then just remember those comorbid conditions, right? So not only are we concerned with the viral load, not only are we concerned with opportunistic infections, now we're also concerned about anybody who has any other problems. And we'll just use diabetes as an example, right? Because now I got to treat for diabetes, but I still have to treat for viral load, and I still have to treat for any opportunistic infections that can occur. So this could be a handful as one patient. So keep all those things in mind when you're looking at treating folks. All right. I'm not going to ask you a whole bunch of HIV/AIDS medications. Okay. Here are a few examples of some of the medications that are out there. Okay. Targine, Genovia. Those are a whole bunch of different kinds, right? Overall, there's probably about 5 main classes of antivirals for HIV and AIDS or so. You guys remember from pharmacology. But the standard is a combo therapy of generally 3 drugs, and generally the 3 drugs, 2 of them need to be different classes. Okay? So as long as you remember that part, when you go to look for certain test questions, you can pick those out. But I'm not going to ask you a whole bunch of stuff because there are so many medications for HIV and AIDS. So many. There's at least 7 per class. 35, 70 to 35 medications that can all be used in different combination. Okay? None of these are usually used alone. As you can see, each one of these individual pills has 2 to 3 medications in it. Okay, up to 4. Yes, ma'am.
Are you putting the medications in the test like generic and in parentheses the brand name, or just for full generic?
Okay, did everybody hear that? On the test, am I putting both generic and brand name? Usually I just put generic on the test. Okay. If I use medications, usually it's just generic. Right? That's what's going to be on your pants as well, generic. If there's one brand name and it's just one, then usually the pants will go ahead and do generic and brand name. Or they may use brand name if there's just one. But in most cases, it's just straight up generic. One big thing that we have to remember when we are actually giving patients antiretroviral medications is a thing called IRIS, immune reconstituted inflammatory syndrome. It's not a real test. It's just for you to be aware of. As that viral load decreases, technically the patient should get better, right? But when you start treating them with these medications, the viral load gets better, the body may notice other diseases that it has. So it may start spurring up some inflammatory processes, and with those inflammatory processes, you may get other symptoms. So that's part of that IRIS process. So a patient may actually get a little bit worse when you start treating them with this, because other disease processes may start popping out as they start getting better. So it's just something to think about when you're actually treating patients. So here's a whole bunch of different medication classes, right? And the importance of this slide, right? Here where it says 3, 3, and 3, right? 3, the reverse transcriptase area, is where these 3 medications work at. Okay, this one's number 7. This one works out here, inhibiting its ability to continue to procreate once it leaves. Okay. So each one of these things works at a different part of the cell. Right? So the importance is to know that we have a lot of different armament in our arsenal to fight at different points within the cell to stop this thing from continuing to move forward. That's what this means. Okay. Prevention is always best. Right? Safe sex practices, safer lifestyle. But it's extremely important that they take their medication at the same time every day or every week, depending on the dosage. All right. And here's per the CDC, viral load is undetectable. The risk of transmission is virtually absent. Okay. The new buzzword is undetectable means untransmissible. So if I can't detect a viral load, my likelihood of spreading it to someone else is very, very minimal. This is all new stuff that's been popping up because with the new medications that have come out. You couldn't say this 5 years ago. All this stuff that you guys are getting now is incredible. It's awesome. You guys have stuff now that can help. Versus when I was doing it in practice. My license is in Florida. In Florida, HIV is a huge thing. So as part of my licensure requirement annually for the state of Florida, I had to do at least 1 HIV class every year. Nowadays, we've got enough stuff that it helps us drastically take care of patients better. Okay. There it tells you if an individual stops taking their meds, their viral load will increase. Okay. We didn't make the stuff go away. We just decrease the viral load replication. That's what all those meds do. They decrease their replication, but the body still has that virus in it. So obviously, if they stop taking it, then the viral load's going to go back up. Right? Viral suppression is defined as less than 2 to 400 copies based on different studies of HIV, RNA. Right? Approximately 80% of people were virally suppressed at their last test. That means that 20% of people were not. Because 20% of people, you need to figure out what combinations actually work for them, or figure out what specific HIV strain they have to target the appropriate antiviral that you're going to need to use. And condoms should still be part of that preventive cycle, right? Safe sex. Here are the big things from this one is, you can have your CD4 count, right? Greater than 200, less than 200. That's where they're going to define how you're going to treat. Right? And HIV viral loads, keep those, monitor those whenever you're making any kind of changes in any of the medications that you're given. Okay? Because that'll show you trends, whether the viral load is going up or going down, whether the medications that you're giving them is actually working or not working. So that is one of the better ones that you should use to monitor. And then clinical status. Okay, that just means that they don't have any opportunistic diseases. If they do have an opportunistic disease, then you need to target the opportunistic disease. All right, that's all that clinical status means. Okay. Is this an occupational hazard for us? Yes. I used to be a first assist. I used to be a surgical first assist. I've been stuck with a couple of needles here and there. Not on purpose, but I have been stuck. Saving grace, they haven't had HIV or AIDS, but some have had hepatitis. Okay? So when I tell you, hey, why should you probably wear gloves when you're dealing with patients? Okay? I mean that sincerely because I don't want to see you guys get anything. Okay? But whenever you're dealing with HIV or AIDS or bodily fluids, right, make sure that you try to protect yourselves. Okay? Now, you have situations like this. Right? I used to carry gloves and a little face mask thing in my glove compartment of my car in case I had to pull over. And I've done that a couple of times in accidents where I pulled over and made sure people were okay. I don't know what those people got. Saving grace is that my gloves are still okay. Now here in San Antonio, my little face mask is one big blob of plastic, as are my gloves. They're one big blob of plastic. So, the question really would be for me, and bad stuff happens if I do pull over and I'm going to touch a patient. Versus, right, you look at the right of the convoy, I knew my guys. I knew what they had, I knew their medical issues. Did I feel comfortable touching them with no gloves on? Well, that shit happened. It didn't matter. But you need to take care of it. So if you have to, just do it. Okay? A lot of times we don't have that luxury to put those gloves on. But that'll be up to you whether or not you know your patients, you know your soldiers or not. Okay? But how comfortable you'll feel in doing it. Okay? There's just two different situations to think about. Here your risk to get stuck with a needle versus, coming in contact with some mucous membrane. Or if you look on the right side, all that stuff can spread HIV. Right? So come into contact with any of that stuff. Possibility is that you may, keyword may, not necessarily get, may, because the number is very small to transmit to healthcare providers when they come into contact with some of this stuff. You guys know what JACO is? They've got a new name. Those are the guys that go and inspect and certify hospitals. This is one of the things that we check. Do you have an SOP for personnel that get infected by something? Okay, in our cases, it would be HIV. Right? They get exposed. So whenever you go to wherever you go, take a look at that SOP. I don't tell you what you need to do. Generally, it'll be wash your hands or wherever got stuck, and then go to the emergency room. They'll draw blood from you, they'll draw blood from the patient, they'll figure out what's going on, They'll check you for 3 months, 6 months, and 1 year. They'll give you meds if they need to. Right? But make sure you read your SOPs. Okay? A lot of folks think, or at least they used to think, that this used to spread HIV. Although some of these have small bits of HIV particles in it, the stuff is not enough to spread HIV to someone else. Okay? So this is more for educational purposes, that this stuff doesn't actually spread. Now, if it is contaminated with the blood itself, blood does have enough HIV viral load in it to spread it, so you gotta be careful. Okay? Here, approximately 0.3% following percutaneous exposure, and approximately 0.09% following mucous membrane exposure. So the numbers are really, really low for transmission of this, according to your job. Okay? And this one is taken straight from the CDC website. Approximately 150 possible transmissions have been reported to the CDC. Only 58 cases of confirmed occupational transmission of HIV to healthcare workers have occurred in the U.S. Okay, and this is as of last year. So that's not much. Okay, so types of exposure: solid needle versus a hollow needle. Hollow needle, higher likelihood of you spreading it than a solid needle. Solid needle won't hold as much of the bodily fluid from an affected patient. Okay. There, they'll look at the status of the patient. If we're talking HIV, whether they're class 1, class 2. Because if they do have viral load in there, then they'll be a little bit more cautious with you. Now here we're talking about post-exposure prophylaxis. Okay. The nice thing about this stuff is that we can give it out now. We couldn't before. What I need you to know from this slide, and I don't usually ask very much of time periods from a lot of our slides, but this one, all meds are given for 28 days. All meds for any of these folks that are post-exposure are given for 28 days. And the CDC recommends that post-exposure is given for 24 to 36 hours. Anything beyond that, we don't necessarily know if it's going to be effective or not. Okay? Anything beyond that, we don't know if it's going to be effective or not. Now, when you're doing this, make sure you check the liver and you check the kidneys. Some of these antivirals may get processed through the liver. Some of them, most of them, get processed through the kidneys. So make sure that you check the liver and the kidneys when you start giving out these medications. See, there's a whole bunch. So initially, you've got the top tier there. You can actually, this one right here, you can just cross off. Okay, we stopped using streptozidine a while ago. Not good side effect profile. Okay, so we got a whole bunch of other ones, so you can just get rid of that whole one. We still use lamivudine every once in a while, as you can see in the first one in Combovec, but the streptozidine is basically gone because we don't really use that anymore. If the top part is not enough, then we'll go ahead and do the top part plus the bottom part. So instead of 2 meds, you'll have 4 meds. Okay. If the top part doesn't work, when we're talking post-exposure stuff. And that's based on location and HIV strain. All exposed healthcare providers should receive the following regardless of whether they receive PEP or not: follow-up counseling, post-exposure testing, and medical evaluation. A lot of this stuff sometimes becomes a psychological issue. Oh my God, do I have it? Oh my God, am I going to give it to my spouse? Oh my God, am I going to give it to my kids? Oh my God, am I going to be able to continue to work? It does become a psychological issue for some folks. So some folks may need some counseling if it does get to that point. Right? And there it tells you You'll get initial baseline in 6 weeks, 12 weeks, 6 months, and a year. Okay, general principles, right? We look at deployability. Okay, none of these guys are supposed to go to combat zones. None of them are supposed to be deploying over there. And it's just a standard. If they are still effective soldiers, sailor, airmen, okay, we are going to keep them. What we do is we transfer them someplace where they don't deal with patient care. All right. Sometimes we'll send them to the schoolhouse if they have a lot of deployment experience, okay, so that they can share what they know. You have to let them know you can no longer donate blood. You cannot be an organ transplant person on your driver's license or on your military ID card. Okay. And then you really got to talk to them about the medications, right? Depending upon which one they can afford, which one they're going to give them, how they're going to take it is what the rest of their life may be taking all this medication. And then each one of our services, we all follow a slightly different thing, but regardless of what we follow, we still take care of our own and we don't just kick them. Especially if they're still effective soldiers. Right? Here they're generally going to be followed by an IV specialist. But remember, once that specialist has got them cleared and they're at another job, they may end up on your panel. So hopefully you'll get one that's pretty clear with what they've got so that you're aware. Because if they end up with some kind of opportunistic type disease, then you really need to start talking to the ID doc or get them over to the ID doc so that they can follow it. Right? For day-to-day stuff, it shouldn't be bad. Okay. Here's some regs. All right, Truvada. This is kind of important because now we're going to PrEP. P-R-E-P, not P-E-P. Okay? This is for people not infected with HIV, but they have a partner that is infected with HIV, or they are at high risk to get HIV, like IV drug users. Right? So here at Truvada, CDC recommends for pre-exposure prophylaxis in a certain population, it takes approximately 20 days for max blood concentration, so it takes about 3 weeks to become effective. Okay, so you need to have a negative HIV test 7 days prior. You need to have a comprehensive STD screening, including oral and rectal GNC swabs. And you need to have creatine clearance, checking your kidneys, that was prior to the initiation of therapy. And here it tells you recommendation every 90 days for HIV. All right. 90% effective rate. Okay, but like in 2016, New York Department of Health reported a case of multi-drug resistant and PrEP-resistant strain of HIV in a PrEP-adherent patient. Testing was done on blood and hair, and the patient was found to be compliant with PrEP with sufficient drug levels in his body, and it didn't work. Okay. So there's still a portion of the population where this stuff is not going to work. When we talk to folks, we need to let them know we can do PrEP for you, but there's a slight chance, about 10%, that it may not protect you. So really, prevention and education is key. Hey, stop doing IV drug use. Want us to help you and put you into counseling, right? Let's decrease that unhealthy lifestyle. Are you using protection? Okay? These are all conversations that you need to have with these people. Now, the magic number for this is you have to be greater than 77 pounds in order to use Truvada. Right. Okay, here's some more HIV PrEP. This one is from SAMC. They kind of want us to use the Scovy. Okay. It's basically the same medication as Truvada, except for he's got a different formulation of the tenofovir. I think there's 3 different formulations for tenofovir, and this one is slightly different than the one that's in Truvada. It's specifically approved for receptive anal intercourse, not studied for vaginal penetration. All right? So big things to keep in mind. Now here, same general recommendations for lab testing and Truvada, right? You do all those tests. General cost, $1,800 to $2,000 per month for either brand. So, if I don't use those brand names, are they generics? Yes, there are generics. Okay. The Descovy pill can run anywhere between $60 to $67 per pill, and it's once a day. Okay. How much do you think the generic pills cost? 500? So obviously generics gonna cost less, right? But we're still talking $30 a pill, and pills every day. Okay. So things that we need to think about when we're talking to our patient: what can you afford? What kind of lifestyle you have? Do you have insurance? Are you paying for this out of pocket? Do you have a copay? Can you afford the copay? A lot of things that you need to talk about as a patient when you talk about what you're going to start them on. Okay. I'm not going to get into this one. The big thing with this particular article, I guess, is that you can transmit HIV from female to female by female to female intercourse. Okay, that's literally what came out of this article right here. I'm not going to cover that, but again, just understand there are times when female to female intercourse can lead it. Now, the only difference with this female to female intercourse is that they were rough enough that they caused bleeding. So the thought process is because they were exposed to blood along with some of the nuchal fluids, that's what actually got the person infected. Okay, that's all this article here is in reference to. Okay, anybody have any questions? Yes, sir.
The antibodies are detectable 100% in 3 months. So for post-exposure checking, are we not for post-exposure prophylaxis is what you're saying to check us all the way up to 12 months. But prior to that, the antibodies detected this are 100% detectable. So I'm just asking that where we're all the 100% safe now.
Well, the standard number one is to go all the way out to 12 months per most SOPs at most locations. But then the other piece is you need to figure out whether it's going to go up or down, especially if you decide to start them on antivirals at that specific time. We still need to figure out whether or not, hey, I'm just starting on this stuff now. I need to know whether it's good or bad. Or do I need to change your antivirals? Any other questions before we move on? No, yes, maybe? All right. Who has not had the flu in this room? Last semester there were some people that said they never had the flu. All right, so you guys know what the flu feels like? Yes, no, maybe? Yeah? It's like a cold that worse, your body hurts, you have some serious fevers, yeah, cough, sore throat. Bless you. Influenza right there. Patient here.
Right on cue.
Okay, so we know this has annual curiosity, right? Nothing new, nothing that we don't already know. In temperate climates, usually it's not as early as October. peaks late December and March, right? This thing says early October, generally we start our influenza stuff around September, October, right, in the military. Okay. Tropical climates, maybe year round if they get it. Okay. Transmissions, just the small particles that get aerosolized when you cough, sneeze, yell, scream, sing, all that stuff makes that stuff come out and you just spread it to somebody else. Okay? Simple, right? Nothing hard. All right. This is where it gets a little funky. Influenza A. Okay. Major outbreaks of antigenic shift. What is that? That is an abrupt, significant change of the virus, often ending or emerging to new viral strains. Okay. The proteins on the outside combine with the proteins of another one, and it creates a completely different strain. Bam, from one day to the next. It's that fast with antigenic shift. Antigenic shift is what's responsible for the Spanish flu epidemic in 1918 that killed a whole bunch of people. Right? So antigenic shift is the bad one. That's the one that causes pandemics. Versus antigenic drift, which is a gradual, continuous process of genetic mutations of the outside aspects of the protein on the influenza virus. Okay? Those are the ones that cause us outbreaks at schools, here in the military, right? Because it just changed from this type to this type, just because some of the proteins on the outside got shifted, right? So that causes us, the pharmaceutical companies, to make new influenza vaccines every year. Okay? So the antigenic drift is what causes us to have new vaccines every single year because of that. Right? Because of those small mutations in the proteins of the outside portion of the virus. Okay? Now, influenza C is the same. It has antigenic drift, but it's not as prominent as B. There, your antigenic shift, major genetic changes results in pandemics. That is the 1918 Spanish flu. Those really create a brand new viral strain. Where it says that antigenic drift, which is those kind of minor genetic mutations on the outside protein, where we need to get new vaccines every year. So who's affected? Children, highest attack rate. What does that mean? Okay, highest attack rate, you can see that now, you can see that in the military public health stuff. Right? It is the proportion of individuals in a given population who become infected over a specific time period. Right? So we know when the flu season is, we know that it's going to be kids. Okay? So the population is kids, and it's the over the flu time period. We know that kids have the highest attack rate. That means that they are the most vulnerable population. That's what that means. Okay. Now, with that said, kids are the most vulnerable population. They're the ones that most commonly get it, but they get over it, they get better, no issues, no problems. Versus the elderly, generally over age 65, lowest attack rate. Okay. So their immune system's a lot stronger for the most part. Okay, so they can kind of sort of protect themselves a little bit from some of the influenza stuff. But when they get it, okay, they have the highest complication rate. And if you look at it, highest mortality, 80% of deaths are in the elderly. And 80% of influenza deaths are in the elderly. Does influenza kill people? Yes, influenza kills a lot of people. Okay, mostly older folks and mostly folks that have comorbid conditions. Those are generally what influenza attacks and kills. Well, this stuff can't kill people. Okay? And here it tells you one day before symptoms actually start is when you actually are kind of infected and start spreading. Okay? Illness onset, even though you'll have some viral prodrome, fever, chills, severe myalgias, and severe headaches. That's not what you'll have before it completely kicks in. Right? That's your prodrome phase. Some folks, when we talk about the flu, know exactly the moment when the symptoms started because this is a rapid onset. Influenza, rapid onset, completely different than the cold. The cold is a slow, gradual onset. Influenza is rapid. It's like, yeah, the symptoms started like 5 days ago. You literally know when the stuff starts bothering you. That's one big way to tell the difference between influenza and a cold. Here's some more symptoms that you may have: photophobia, coryza, sore throat, dry throat, severe dry cough, anorexia. Okay. If you don't remember what coryza is, just inflammation of the mucous membranes inside the nose and throat. Right? Nasal congestion, runny nose, sneezing. But here's a chart. Those last 3 slides you should probably remember. I think those are going to be on the test. Include this one. This is how you differentiate the cold from the flu. And there it's pretty clear: a rapid onset, rigorous fever, sweating, symptomatic changes, systemic changes, or symptoms, severe malaise, myalgias, fatigue, anorexia. Okay? And you can compare them. Flu's much worse than the cold. Okay, what are you going to do? CBC count? Not really going to tell you much. What are you going to do for influenza? It's a virus. Right? You can do viral cultures there. They're going to take 72 hours. They're really going to matter at that point. Right? So you can nasal swab somebody, throat swab, you sputum, send it off. We do have the rapid influenza test, which is kind of nice. So when you see someone in the clinic, you think it's influenza, you can just order a rapid influenza test. You can have them sit in the waiting room. We'll wait about 15 to 30 minutes is usually what it takes for the results to come back, and you'll know whether this person does or does not have it at the present time. Right? Now, if he does, and it is less than 48 hours, it's kind of nice. You can go ahead and start an antiviral if you want. Otherwise, you don't need to. Okay? Your choice. And then you can do serology, but it's going to take a couple of days to figure out what you're doing. By that time, the person's probably already feeling better. And then PCR, but PCR is pretty expensive, and there's no reason to do that when you can do a rapid influenza. And just remember, rapid influenza isn't 100%. Okay? So just because it's negative doesn't mean that you're negative per se. Okay, so what are you going to do? Symptomatic treatment, acetaminophen. Nowadays, we use acetaminophen. We do not use aspirin. Not use aspirin, especially in kids under 16, because it causes Rye syndrome, but generally we don't use aspirin anymore. Okay? And you consider antivirals if less than 48 hours. Okay? If you've had symptoms for less than 48 hours, and you can consider, key word here is consider, you don't have to, even if it's less than 48 hours, right? If you're a healthy person, I really need to give you an antiviral even though it's less than 48 hours. The benefit has been shown that it only decreases the illness by 1 day. Now, for you, healthy people, I don't think that really matters, right? What we're talking about is older folks, folks with comorbid conditions, immunocompromised folks, neutropenic folks. Those are the folks that you should really keep in mind for this, because it can decrease its effective aspect on you, on the individual patient, and it can decrease the overall course of the illness. It may only be by 1 day, but hopefully it will decrease a lot more of those symptoms for those folks that really cannot handle this stuff. Okay. Now, which one would I use? There are some pockets of strains, depending upon geographic location, whether it be around the world or here within the U.S. Your Stanford's guide can help you with that. But otherwise, what we generally use would either be Zanavir or Oseltamivir. Okay, either of those two will work. Right? You guys remember that little H1N1, right? You guys remember that? The hemagglutinin is one, and neuraminidase is the other. Those are the proteins that sit on the outer portions of this influenza stuff. That'll tell you the strain that it is. Right? So there it tells you which one N1, and it'll also tell you which 3 and 2 for Zanavir and Oseltamivir. Okay? So we know that it works for those things. But if you do have one, right, that does show some resistance, you can try Baloxavir. Okay? if you really need to, depending upon where you are. Some places in the military we do stockpile. I know when I was with Special Operations South, we stockpiled some also Tamavir in case we were deployed off quickly, but we were having an outbreak of the influenza virus. So we had some of that stuff stashed. Vaccines, I am shot annually, right? Everybody here has had an influenza shot? Yes? Okay. How many of you have had the flu mist? Okay. So let me put it to you this way, right? We're conducting a study. If I give you a live virus versus giving you a dead attenuated virus, which one do you think will cause my body to have a better reaction and develop better antibodies to protect me against influenza? The live one or the dead attenuated? So this room said live. This side of the room said live. From what I heard, right? What did you guys say? What? I'm deaf, I'm fat, and I'm old, man. I can't even shake. What did this guy say? Right? So it kind of makes sense, right? Live would be better. But the studies did not show that. The studies did not show that. Okay? I was a big proponent too, right? I was not a big proponent for the flu mist, but understanding some of the pathology, you would think that the live one would be better. But now we have to think about the other aspects of the live one. Right? We have to keep it within a certain temperature. If it leaves that temperature, it may die. So I can squirt something up your nose, it may be dead, and it's not going to do anything for you. If you don't squirt it up the nose appropriately and it doesn't get to where it needs to go, then it really doesn't do anything for you either. Okay? So right off the bat, we got two places where we can make errors and mistakes with the live flu mist, which is what really occurred, right? We had a chain of custody issue. We weren't keeping it at appropriate temperatures, right? We were keeping it at appropriate temperatures at the site where we were giving it to people. So there was a lot of things that were not working out very well for us. So the military has gone away from flu mist, and we only do the shots, all right? Two different kinds. We have the pre-filled syringes, and we have the vials. Okay. The vials, most of them do not have any more thimerosal. That's what a lot of folks are attributing to that stuff the kids have? Autism. Okay. There were, see, I have some autism too. That's probably my old age, severity. Because there was such an uproar, most of the vaccines, not just influenza, have removed thimerosal from the vaccine itself, and it was just used as a preservative. Okay? So for us, if you guys are concerned with that, you guys need to look at the insert that you're getting with whatever vaccine you get. Just understand, the single injections do not have thimerosal in them. Only the vials may have thimerosal. It's dependent on the company. Okay? So you guys can take a look at some of that. We have a couple of different kinds of vaccines that we have for influenza. We have the inactivated, which is what I call the attenuated. We have the live attenuated. We have the recombinant, and we have the adjuvant. Okay, so we have a couple of different ones. The adjuvant vaccine, these aren't going to be on your test. This is more for you to understand and know, right? Especially if you're going to go practice in the civilian sector. The adjuvant vaccine is one that has MS5 in it. And what that's supposed to do, it's supposed to increase their body's reaction to the vaccine. And usually we give those to folks that are 65 and over. Okay? Because we need their body to kind of react to it and create better antibodies for this stuff so that they don't get sick. The recombinant one is usually made out of some crushed up insect protein that replaces the egg that we used to use in the past, specifically for the folks that are allergic to eggs. But now, the inactivated, which is usually made through still eggs, have been filtered enough that it doesn't matter if you're allergic to eggs or not, you can still get it nowadays. And then the live attenuate is basically like the famous, where it's actually weakened live vaccine. Okay. I think we need to stop here. Yeah, we need to stop here. All right. So we'll pick this up tomorrow.